is Ulrich Specks. I'm the chair of the Pulmonary and Critical Care Division at Mayo Clinic in Rochester, Minnesota. I've had a longstanding interest in taking care of patients with ANCA-associated vasculitis and have participated in many clinical trials that have contributed to the current standard of care for patients with ANCA-associated vasculitis. Today, I will provide you with an update on the management of ANCA-associated vasculitis. Here are my disclosures. The ANCA-associated vasculitides, particularly granulomatosis with polyangiitis or GPA and microscopic polyangiitis and MPA, are classified as small vessel vasculitides because they predominantly affect the capillaries and small arterioles and venules. However, they can, on rare occasions, also affect larger vessels. They are associated with circulating autoantibodies that are referred to as anti-neutrophil cytoplasmic antibodies, or ANCA, that come in two varieties. The C-ANCA pattern is caused by antibodies directed against proteinase 3 or PR3 and is most common in patients with GPA, whereas the predominant ANCA type in microscopic polyangiitis is directed against myeloperoxidase or MPO, and it gives a perinuclear staining pattern on ethanol-fixed neutrophils. The focus of this presentation will be on GPA and MPA and its management. The third ANCA-associated vasculitis is EGPA, or formerly called Churg-Strauss syndrome, which will not be the focus of this presentation. GPA and MPA have renal involvement in 70 to 85% of patients over the course of their disease, and therefore the focus of this presentation is on GPA and MPA. I hope that the attendees of this webcast will be able to summarize the current state-of-the-art treatment for GPA and MPA, as well as recognize unmet needs in the management of GPA and MPA. Also, I will mention ongoing clinical trials and how they currently address these unmet needs. And hopefully, after completion of this presentation, the audience will be able to understand the direction of clinical research efforts in the field of ANCA-associated vasculitis. So the status for remission induction therapy currently is focused on stratification of the patients by disease severity. Nephrologists do not need to preoccupy themselves too much with the non-severe disease manifestations of GPA, as they mostly affect the upper and lower respiratory tract. Once the patient has kidney involvement, they are classified as having severe disease, because the definition of severe disease is that of either life-threatening disease or threatening the affected organ with the risk of irreversible damage. And as such, kidney involvement leads immediately to renal damage if not treated effectively and clearly, and therefore renal involvement classifies the patient as having severe disease. So from here onwards, we'll focus on remission induction therapy for severe disease manifestations, including renal disease manifestations. The clinical trials over the last decade have established rituximab as the preferred alternative to cyclophosphamide for the management of severe GPA and MPA, because rituximab is non-inferior to cyclophosphamide for all patients with severe AAV, and it has been found to be superior for patients who present with disease relapses or with PR3 ANCA. For patients with MPO ANCA, cyclophosphamide and rituximab are equivalent. Whenever you introduce a new drug, particularly a biologic, the cost of the drug becomes the focus of discussion, and rituximab is unfortunately much more expensive than cyclophosphamide in most healthcare systems. However, when one discusses the economic cost of a treatment, one has to consider not only the drug cost, but also the healthcare system in which the drugs are available, the insurance environment, as well as the cost of the overall treatment over a lifetime of a patient. So the economic cost is always one that goes beyond the immediate drug cost or the immediate cost to the insurance company. So in that sense, a drug that is more effective and has less toxic side effects may be cost effective, even though it is more expensive. The group in Oxford evaluated the use of rituximab versus cyclophosphamide in an economic efficiency calculation and concluded that rituximab was indeed cost effective for relapsing patients, but it was not cost effective for newly diagnosed patients. However, the basis for this analysis was the RAVE trial, and the authors based their analysis on the relapsing patients versus newly diagnosed patients. However, since in the RAVE trial, as I'll show you later, rituximab has been shown superior to cyclophosphamide in efficacy for patients with PR3 ANCA also, and the relapsing patients and the PR3 ANCA patients largely overlap, one could also extrapolate that had the analysis been based on PR3 ANCA versus MPO ANCA, the conclusion from this cost consideration study would also be that rituximab is probably cost effective for PR3 ANCA patients, whereas it may not be cost advantageous for patients with MPO ANCA. The clinical trial outcomes of the RAVE trial have clearly shown that amongst the PR3 ANCA patients, superiority over cyclophosphamide was achieved at 6 months. And for patients who entered the trial with PR3 ANCA positivity and relapsing disease, the superiority was not only documented at 6 months, but also for 12 months and 18 months after a single treatment with rituximab. What about patients with severe renal disease, as well as those with respiratory failure? There is a myth out there that cyclophosphamide should be used instead of rituximab, or cyclophosphamide should be added to rituximab for the management of such patients. This myth is based on the fact that the RAVE trial excluded patients who had a serum creatinine greater than 4 at the time of enrollment, and it excluded patients who presented with respiratory failure requiring mechanical ventilation as a result of alveolar hemorrhage. These exclusion criteria were requested by the Data Safety Monitoring Board prior to approving the trial. The rituximab trial was a trial that was conducted in Europe, and it enrolled patients with more severe renal disease. And in these patients, the rituximab treatment arm also contained 2 intravenous boluses of cyclophosphamide. However, one could argue that there is no significant biological difference in a patient who presents on Friday afternoon with a creatinine of 2.8 versus presenting on Monday morning 2 days later with a serum creatinine of 4.2 as the disease has progressed. If the patient had signed consent for enrollment into the RAVE trial on Saturday with a creatinine less than 4, the patient would have been enrolled, whereas had the patient been approached for participation in the RAVE trial on Monday morning with a creatinine for 4.2, the patient would have been excluded. Similarly, diffuse alveolar hemorrhage with oxygen supplementation requirement of 4 liters per minute by nasal cannula on Saturday would have been enrolled into the patient, but the patient could have easily progressed to needing mechanical ventilation by Monday and therefore would have been excluded on Monday. The biology is the same. It's just a matter of when the patient was seen, how far into the progression of the disease the patient was seen, and therefore we should not expect a different response to treatment based on this arbitrary disease severity definition. In fact, a quarter of the patients in the RAVE trial did have alveolar hemorrhage, and their overall treatment response was similar to the entire cohort. Only none of these patients, at the time they signed consent, required mechanical ventilation. So what about patients who required mechanical ventilation for alveolar hemorrhage caused by GPA and MPA? We looked at our patient cohort at Mayo Clinic of all patients with diffuse alveolar hemorrhage caused by GPA and MPA, and a sizable proportion of these patients did require mechanical ventilation. At Mayo Clinic, we use remission induction regimens either with cyclophosphamide or rituximab, but never both in combination. Therefore, we were able to compare the outcomes of patients who had remission induction with glucocorticoids and cyclophosphamide versus patients who had remission induction with glucocorticoids and rituximab. The hospital mortality was the same. The hospital lengths of stay was the same. So was the intensive care unit lengths of stay or the time spent on mechanical ventilation. However, what was different was the rate at which patients achieved complete remission by 6 months, complete remission being defined as having no vasculitis activity and having completed the glucocorticoid taper to 0. Almost 90% of the patients treated with rituximab achieved that outcome compared to almost 70% of patients treated with cyclophosphamide. The combination of cyclophosphamide with rituximab goes back to the RituxVAS trial, as previously mentioned, as in this trial, the treatment arms consisted of a standard intravenous cyclophosphamide IV bolus treatment for 6 months, followed by daily oral azathioprine. The rituximab arm was dosed at 375 milligrams per meter square times 4 once weekly, and at times at week 1 and week 3, patients also received an intravenous bolus of cyclophosphamide. And based on that regimen used in the RituxVAS study, many nephrologists think that in patients with a creatinine greater than 4, there might be an advantage to using this combined therapy. The RituxVAS trial has shown equivalence of the 2 treatment arms in every outcome. To address this question, whether these IV cyclophosphamide boluses were at all needed, Dr. Geetha from Johns Hopkins, in collaboration with Dr. Jain from Cambridge, conducted a retrospective analysis of their patients with severe renal disease, defined as an estimated glomerular filtration rate of less than 20 milliliters per minute. 12 patients received glucocorticoids and rituximab alone, 25 patients received glucocorticoids and rituximab and intravenous cyclophosphamide boluses. The baseline eGFR, the frequency of additional use of plasma exchange, and the rituximab dosing regimens used were equivalent between the two treatment groups. And the authors could not detect any difference in outcomes, whether it was remission at 6 months, the likelihood of developing end-stage renal disease or death, or the recovery of renal function. And the conclusion from this retrospective study would be that there is no benefit to the addition of cyclophosphamide boluses in patients with severe disease. So to summarize the status of induction therapy in 2019, other studies, in addition to the RAVE trial that had shown non-inferiority of rituximab to cyclophosphamide in all comers, as well as superiority of rituximab to cyclophosphamide for patients with relapsing disease or for patients with PR3 ANCA. The additional studies have shown that their rituximab is at least as good as cyclophosphamide, even in patients with severe renal disease and patients with alveolar hemorrhage requiring ventilatory support. Now, this slide summarizes the mortality over time for GPA and MPA based on several clinical trials conducted by the European Vasculitis Study Group. This data summarizes data that precede the use of rituximab. What this shows is that there is an early mortality signal in the first year, particularly in the first 3 months. So the highest risk for the patient of death is in the first 3 months. And a more detailed analysis of the cause of death of these patients showed that almost half of the patients died of severe infections, and only 20% of the patients died from their underlying vasculitis. So this suggests that there is room for substantial improvement in managing the early acute phase of the disease, and that we need to prevent infections if we want to substantially reduce the early mortality. A second crucial observation has been published by a group in the Netherlands, and what they show has been shown in other studies also. In essence, what this graph shows is that the renal disease ultimately determines the overall outcome of the patient. Specifically in this study, it was shown that patients who end up on dialysis and require dialysis ongoing have a much higher mortality than patients with renal involvement, but not requiring renal replacement therapy. The patients who do not require renal replacement therapy have the same overall outcomes as patients who don't have renal disease in the first place. So the determinants of long-term renal survival also were found to be the level of renal function at 6 months, as well as having suffered a renal relapse over the course of the disease. So the overall outcomes and overall survival of patients with ANCA-associated vasculitis is very clearly linked to the renal function at the end of remission induction therapy. So saving as much kidney function as possible, as early as possible, has the most profound effect on the overall outcome of the patients. So what are our opportunities for improvement of remission induction therapy in 2019? We clearly need to improve the early mortality, and we need to minimize toxicity of the drugs we use, particularly the infectious risk inherent to glucocorticoid therapy. We also need to minimize tissue damage and particularly the renal damage. How can we achieve this? What is the role of plasma exchange to achieve these goals? And are there any novel drugs that potentially help us achieving these goals? These two questions I will address in the next few slides. The question about the benefit of plasma exchange has recently been addressed by the largest clinical trial conducted in ANCA-associated vasculitis, the PAXIVAS trial. The PAXIVAS trial was conducted globally, enrolled 700 patients, and had a factorial design outlined on this slide. Patients received standard background therapy consisting of cyclophosphamide or rituximab as the backbone of induction therapy. Patients were then randomized to either receive adjunctive plasma exchange or no plasma exchange, and patients were further randomized to receive a standard glucocorticoid dosing regimen and tapering regimen versus a more accelerated glucocorticoid tapering regimen, resulting in a cumulatively substantially reduced glucocorticoid dose. The primary endpoint was combination of end-stage renal disease or death. The key results of the PAXIVAS trial have been presented at clinical meetings in 2018, and the results are currently undergoing peer review for publication. The headline results are that there is no benefit whatsoever to the addition of plasma exchange, either when we analyze the entire cohort or when subsets of severe renal disease or subsets of alveolar hemorrhage were analyzed separately. So the PAXIVAS trial confirms observations done in cohort studies previously. The most interesting and practice-changing outcome of the PAXIVAS trial is, however, what was observed with the prednisone dosing regimen. It became clear that there was the same efficacy of both glucocorticoid dosing regimens, both in terms of primary outcome as well as secondary efficacy outcomes. However, the lower dose glucocorticoid regimen was better in terms of having a lower infection rate. Therefore, it is a safer approach that provides the same efficacy. So less glucocorticoids may actually be better in the acute phase of the disease. What about plasma exchange for alveolar hemorrhage in GPA and MPA in the Mayo Clinic cohort? We looked at this question also in our cohort that I already mentioned earlier. All of our patients presenting with diffuse alveolar hemorrhage received intravenous methylprednisolone. 32 of these patients also received plasma exchange. And there clearly was a bias towards treating patients with plasma exchange that were sicker and required more respiratory support. Therefore, we did a propensity score analysis adjustment, adjusting for the probability to having received plaques or for the probability of having received rituximab versus cyclophosphamide treatment. And after these adjustments, no association of plasma exchange with the likelihood of achieving complete remission at 6 months could be detected. So we concluded from this retrospective cohort analysis also that there was no apparent benefit of plasma exchange. The literature with respect to alveolar hemorrhage caused by AAV does not provide a whole lot of detail for a lot of patients, but when we summarized all available information about resolution of the diffuse alveolar hemorrhage and hospital survival in patients who had alveolar hemorrhage caused by AAV and added them all up, we could also not detect any benefit to plasma exchange on resolution of diffuse alveolar hemorrhage and hospital survival, whether the patients received plasma exchange or not. What about novel drugs? Can novel drugs help us control renal function early and allow us to get by with less glucocorticoids? The drug that has achieved most interest in this context is interfering with the interaction of activated complement factor 5 with its receptor. The drug now carries the name avacopan. The drug is the direct result of animal model studies conducted in the MPO ANCA associated vasculitis model from the Chapel Hill group. This animal model demonstrated that the lesions are dependent on complement and that an intact alternative pathway is required for the lesions to develop. Moreover, mice that lacked the complement factor 5A receptor on their neutrophils did not develop the lesions. Finally, when the animals, wild-type animals, were given anti-C5a monoclonal antibodies, the disease in the mouse model could be helped therapeutically. On the basis of these preclinical studies, a phase 2 trial was conducted with avacopan, which showed an apparent steroid-sparing effect. So on this slide, we summarize the results of this phase 2 trial, and you can see that the reduction in disease activity expressed as the Birmingham Vasculitis Activity Score was equivalent in all three treatment arms. There was no statistical significance of the activity reduction in all three treatment arms, even though it may appear that the patients who received avacopan either alone or in combination with low-dose steroids seemed to have a more rapid reduction in disease activity than the patients who received the usual high-dose steroid standard of care regimen. What was even more exciting was the observation that a biomarker for renal damage, the urine albumin creatinine ratio, could be beneficially affected within the first 4 weeks in a very significant manner. The patients who received avacopan, either alone or with low-dose glucocorticoids, had a statistically significant reduction in the urine albumin creatinine ratio by week 4, whereas this reduction could not be observed in the patients who received the usual high-dose glucocorticoid regimen. And these observations and the hopes that with this drug and interfering with the complement factor 5 pathway, one could prevent renal damage effectively early and allow steroid sparing was what led to the design of the phase 3 trial, the Advocate trial, that compared avacopan directly head-to-head to prednisone in remission induction of patients with severe ANCA-associated vasculitis. This trial has completed enrollment. The 1-year follow-up period has been completed, and we anticipate an analysis of the results later this year. If the trial delivers on its promise, it would substantially change how much, or if any, glucocorticoid use will be required to put patients into remission. So, what about maintaining remission? Once patients are in remission, since this is a relapsing disease, most patients with GPA and some patients with MPA are thought to require remission maintenance therapy. Most of what we know about remission maintenance agents and their efficacy has been derived in patients who had remission induction with glucocorticoids and cyclophosphamide. Following induction with cyclophosphamide, azathioprine and methotrexate are equally effective. However, of course, patients with renal disease and renal damage are not faring very well on methotrexate, and methotrexate should not be used in such patients. And therefore, for patients with renal disease, the maintenance agent first to consider is azathioprine. Mycophenolate mofetil has been associated with a somewhat higher relapse rate when it was compared head-to-head to azathioprine in one study. And as a result of this study, mycophenolate is thought of being a second-line agent for patients who cannot tolerate either azathioprine or methotrexate. Most recently, and I'll go into more detail of those data, most recently it's been shown that rituximab is actually much more effective at keeping patients in remission than azathioprine. Moreover, what is still unknown is what is the preferred remission maintenance agent following induction with rituximab. So the unmet needs in management of patients during their remission phase is that we need to determine which patients actually need remission maintenance therapy and which patients do not require long-term maintenance therapy. And we want to use the most effective agent that has the least long-term toxicity. Moreover, preventing relapses is directly associated with preventing cumulative glucocorticoid exposure with all its associated toxicities, and it prevents further renal damage coming from renal relapses. Who needs remission maintenance? Several studies, including the RAVE trial, from which the results are shown here, have indicated that patients with PR3 ANCA are at much higher risk for relapse than patients with MPO ANCA. And the patients at highest risk for relapse are those who entered the clinical trial with PR3 ANCA, a diagnosis of GPA, and a disease relapse. The patients who had the lowest relapse rate were those who entered the trial with a new diagnosis of microscopic polyangiitis and were MPO ANCA positive. So the conclusion is that PR3 ANCA positive patients are at high risk for relapse and need to be monitored very closely and in all likelihood require long-term remission maintenance therapy, whereas patients with MPO ANCA and a new diagnosis of MPO ANCA associated disease can probably be followed and do not necessarily require remission maintenance therapy. The Main-Ritson study conducted in France has shown very clearly that after induction therapy with glucocorticoids and cyclophosphamide, rituximab could be used as a very effective maintenance agent that was in fact superior to azathioprine for maintenance. The long-term follow-up of patients in the Main-Ritson study confirmed that this initial superiority of rituximab over azathioprine for maintenance was maintained long-term over the course of 60 months. However, what this study also showed is that after discontinuation of all treatment, there was a continued frequency of relapses in both treatment arms. So long-term remission maintenance therapy is probably needed, particularly for patients who are PR3 ANCA positive and who've had relapses in the past. Now, is rituximab cost-effective to maintain remission compared to the much cheaper drug azathioprine? The French authors actually did an economic analysis of the treatment cost overall and were able to show that the higher drug cost of rituximab was outweighed by the economic cost resulting from the higher relapse rate and particularly the higher renal damage accumulating in patients treated with azathioprine. And they were actually able to put a dollar or euro amount on this use of rituximab, and they quote that the incremental cost effectiveness ratio was 259 euros for every avoided relapse. Now, do we need to give rituximab every 6 months like clockwork, or can we extend the intervals of retreatment based on looking at B-cell reconstitution and ANCA level data? The French conducted the MAINRITZON-2 trial that addressed this question. So patients were randomized to either receive every 6 months 1 dose of 500 milligrams of rituximab like clockwork, which was the regimen used in the MAINRITZON-1 trial. And they compared it to a treatment arm in which patients would only receive a repeat dose of 500 milligrams if either their B cells had reconstituted or their ANCA levels started to rise. And they were able to show that the efficacy of maintaining remission was exactly the same in both treatment arms, but the advantage was that patients who received it in an individually timed fashion required much fewer rituximab retreatment doses, making such an approach more cost-effective. So let me summarize. Rituximab has essentially replaced cyclophosphamide for remission induction in PR3 ANCA-associated GPA and MPA, and at least in our practice, the use of cyclophosphamide is pretty much limited to some patients who present with a new diagnosis of MPO ANCA positive microscopic polyangiitis, where the efficacy of rituximab and cyclophosphamide is the same, but retreatment down the line or relapses are less likely. Plasma exchange is clearly no longer something that should be advocated for use in patients with ANCA-associated vasculitis. All studies that have been published recently, including the most definitive study, the PEXIVAS trial, have been unable to show any benefit of the addition of plasma exchange to standard immunosuppressive therapy. Glucocorticoid avoidance is clearly the primary focus of clinical research in GPA and MPA, and several approaches have been taken. For the remission induction in the acute phase of the disease, inhibition of the C5a receptor engagement with agents such as avacopan offers the most promise of being able to minimize early renal damage without substantial doses of glucocorticoids. However, the phase 3 trial results are eagerly awaited, and at the moment, we cannot draw any definitive conclusions yet. Using lower doses of glucocorticoids during induction regimens have also been used in the Pexivas trial, as well as another remission maintenance trial that compares azathioprine to rituximab. And we hope from the rituximab trial that we also learn something about the efficacy of a more rapid accelerated glucocorticoid tapering regimen during induction. Ultimately, the most effective way to minimize repeated glucocorticoid exposure over the lifetime of a patient is to be most effective in maintaining remission. And in that sense, rituximab has been shown to be superior to azathioprine in the long term. With that, I'd like to thank you for your attention.